Good afternoon. I'm delighted to join this intestinal failure session at the Oley meeting to give an update on the Lift Echo project that I hope some, if not all of you, have already heard a little bit about. Here are my disclosures. I'm a scientific advisor to several pharmaceutical companies, as you see there, an investigator with some of them, and have received grant support for research as shown there. Before I get into the meat of this talk, I want to acknowledge that the Lift Echo project, which really started as a labor of love, has been supported by pilot grants from the Rekanati Miller Transplant Institute and the Intestinal Research Fund at Mount Sinai, where I'm based, from your very own Oley Foundation, and from a generous seed grant from Zealand Pharmaceuticals in Denmark when we launched this project. We've also received a very generous continuing project grant from Takeda Pharmaceuticals that has really allowed us to push the application of the Lift Echo project and take it to where it is today. And I hope you'll agree that there is a lot of potential. Intestinal failure poses several significant challenges. As many of you know, it's a very rare disease with an estimated prevalence in the United States of somewhere between 25,000 to 40,000 cases, probably closer to the lower number. And that in itself says something that we really don't even know the exact prevalence at the present time. There isn't a specific diagnostic code for intestinal failure under the ICD coding system, the International Classification for Diseases. That will hopefully change in the very near future and things may improve somewhat. We know that the best results when we manage intestinal failure really require experienced multidisciplinary teams bringing different types of expertise to bear on a very complex problem. The ideal programs will have really some or all of a combination of gastroenterologists, hepatologists, surgeons, perhaps transplant surgeons, nurses, physician assistants, nutritionists certainly, social workers, and really several other specialists as needed on occasion. Not a complete surprise that for such a rare disease with such complex management requirements, there really are very few experienced intestinal rehabilitation teams around the country. Thus, there are problems of distance, of geography. We all know there are insurance constraints. Even if you wanted to go to an expert center, your insurance company may not authorize such a visit. Thus, there are difficulties in access, and the question arises, should the intestinal failure patient, say in Montana, have the same expertise, same access to expertise as the patient in New York or in Omaha? Is there evidence for this type of generalized lack of expertise? We know, and there is data for this, that most GI fellowship training programs in the United States provide very little specific training in home parenteral nutrition. Equally, these programs provide very little to no specific training in intestinal failure. So we then developed an overarching hypothesis that there is widespread lack of knowledge in intestinal failure care, and we will explore further what this lack of knowledge might lead to. But the fact is that there are no systematic studies of knowledge gaps in chronic intestinal failure, and we recently reported our experience attempting to study this issue. We identified 4 key components of home parenteral nutrition and intestinal failure that we thought constitute relatively basic expertise. We developed a knowledge test of 20 questions with 5 questions in each of these components. We did some internal testing, improved the questions, we got some feedback. We then revised the questions. We reviewed the test with 2 experts in survey construction and in intestinal failure to make sure the questions were easily understood, there was not any confusion, and they were relevant to what we were trying to test. Based on that feedback, there was further revision. We then identified a convenient sample of 20 experts in intestinal failure and 25 non-experts. And the experts were clinicians with extensive record of clinical and academic activity in intestinal failure. Non-experts were fellows in training, relatively advanced trainees in GI and hepatology and transplant surgery. And to try and correct for any impact of age and years of experience, we threw in some liver and kidney transplant surgeons into the mix who had no specific training in intestinal failure. We analyzed de-identified knowledge test scores from 16 experts and 22 non-experts who turned in the test. And you can see right away in the table shown there that the experts seemingly did much better than the non-experts in our test. And when we looked at statistical significance for those who are interested, these results were quite significant. And we looked at, is our test reliable? Do the test questions, are they measuring the same concepts? And without getting into the weeds, the results suggested that our test items were likely measuring the same concepts of broad knowledge in intestinal failure and HPN. Again, I don't want to spend too much time on this, except to say that this concept, this is what's called an ROC curve, and some of you may be familiar with this. But the idea is, if you look at the diagonal, the straight line going across the middle of this square, that diagonal is about the same as flipping a coin. So if you flipped a coin and tried to decide, is the person taking this test an expert or a non-expert, you'd have a 50-50 chance of getting it right, and that's the diagonal. If the test you're applying, it doesn't matter whether that's a COVID test or it's a knowledge test in intestinal failure. If the results of that test move towards the top left corner, the test gets better and better. And you can see that our test actually did quite well with a sensitivity of over 80% and a specificity of over 85%, suggesting that it was pretty effective at distinguishing between experts and non-experts in intestinal failure. Now that we had the test, we took it a step further. Many of you may be familiar with Medscape, an online health information platform that does a variety of things, including providing continuing medical education for clinicians. This is an important part of their work, not the only work that they do. And we've done some work with Medscape before, and they were interested in this project and agreed to help us. And with Medscape's help, we deployed our de-identified knowledge test now to 100 US gastroenterologists. And you can see there we had good participation from California, from New York, from Illinois, but really from a good part of the country, not all of the states, but 31 of the 50 states had at least one participant. And some of the respondents actually claimed to have significant clinical experience in GI, and some even that they were actually managing some home TPN patients. And then we later realized that this question was not completely clear. We should have asked them, were you actually prescribing the TPN? We didn't ask that. But anyway, that's what we got. 55 of the test takers considered themselves expert in parenteral nutrition. This may tell you more about human psychology than it does about intestinal failure. Every one of us is an expert. But here are the results of the Medscape survey. And if you're following what I've been saying so far, you'll see right off the bat that really people did not do well in this test. Of the 100 gastroenterologists, the overall mean and median scores, sort of average scores, were really below the level of, well below the level of our experts, no different from the non-experts in our earlier sample. And interestingly, as I perhaps alluded to earlier, the people who claimed they were experts did not really do much better. They did just as badly. And there are clearly some questions that we still have to tease apart. You know, we don't have a clear definition of who's an expert, who's a non-expert, but it does show that in a relatively well-validated knowledge test in intestinal failure and HPN, from a population of 100 US gastroenterologists, we did not find significant experience, significant expertise really in anybody in that sample. And I must confess to you, and I wouldn't be surprised if I don't get too many greeting cards from gastroenterologists, but obviously this does not include any of my friends who are experts. This was not a surprise to me. This is really what I suspected for a long time. Our knowledge test and this survey confirmed the results, and we recently published this paper in JPEN. So what did we learn? We learned the knowledge of intestinal failure is poor, perhaps at the level of non-experts in this cohort, and it is even possible that people who are experts in home TPN may not necessarily be experts in intestinal failure. The two are obviously related, but they're not the same. I don't want to belabor the rest, but we do think that this supports prior observations, and we need to study this issue further. But so we've now got some evidence that there's lack of expertise. Is there evidence for geographical disparity? Now, we had the opportunity, and Dr. Manpreet Mundi, who many of you should know, really led this project that was supported by Zealand Pharmaceuticals from Denmark. And it was a very interesting exercise to look at a large population, a large US population for whom we had claims data from a very large data set. This was roughly 350 million health insurance claims. It was quite a difficult project that required significant effort to tease apart who really had intestinal failure, who was on TPN for how long. But I've just pulled a couple of figures from that paper. And if you think of this as a heat map that you might have sometimes seen, especially recently in the context of COVID, you'll see that there is each dot on this map represents a single physician who is signing orders for parenteral support. And the blue dots, which are the overwhelming majority, are physicians who are prescribing HPN for anywhere from 1 to 4 patients. And you can see that there's a very large number of blue dots. The red dots are the physicians prescribing HPN for more than 20 patients. And you can see that's a very, very small number. So if you think, and I'm going to spend a minute on this slide, if you think that there are about 25,000 HPN patients, and I'm rounding this data, there are actually about 12,000 prescribers for that HPN across the US. Simple math. Each physician, if you ignore the experts who are, say, prescribing for more than 20 patients, or even more than 10 patients, more than 5 patients, there's a very large number of physicians who are unfortunately having to prescribe PN for 1 to 2 patients each. And that's not a setup that lends itself to accumulating expertise. This was another interesting piece of data that came out of that study. Look at the distance that patients are having to travel to see their HPN prescriber. If you even forget, if you ignore the patients who are traveling over 1,000 miles, I don't know what that's about. Maybe they have specific physicians that they like, relationships with programs, and I can understand that very well. But even on the average, it appears that many patients are traveling anywhere between perhaps 75 to about 300 miles to their PN prescriber, and that cannot be a good thing. Do these disparities in access to expertise have any impact on clinical outcomes? I just want to emphasize that this data is unpublished. I'm going to be presenting it in Vienna at the ESPEN meeting coming up next month. But look at this. It's again a complicated graph. This is work that I had the good fortune to do, and we're continuing this project with a group from Optum, the very large insurance provider, if you like, the sort of corporate flagship of United Healthcare. What you can see here that is that roughly 50% of patients have less than one to two inpatient admissions while on HPN. This is for every 100 days of HPN. So for 100 days, just over 3 months of HPN, we think with intestinal failure, about 50% of these patients, when we looked at a 3-year period, had a maximum of 1 to 2 inpatient admissions, maybe 1 to 2 ER visits. And you'd say for a relatively sick patient population, that is pretty good. But look at the right half of this panel, and at the extreme end, there's about 6% of patients who have over 9 ER visits, emergency room visits, in about a 3-month period with intestinal failure. About 5% have about 10 inpatient admissions in a 3-month period. And you can see this is a very worrisome trend, that there's a significant percentage of these patients with chronic intestinal failure who seemingly are bouncing in and out of the hospital, in and out of ERs. And while some may be unavoidable and may reflect very sick patients, it does seem that some of this is perhaps related to lack of expertise. I will emphasize we've not shown a causal relationship yet. I can't tell you that lack of expertise is what led to this graph. That I can't tell you, but certainly the data at this stage looks suspicious. So, can we do anything about this problem of inequity in access to expertise? And this has been a question for those of you who know me from Oley. This is a question that I've been discussing with several of you over the years. We've certainly worried about this problem and continue to worry about this problem for our patients with chronic intestinal failure or on long-term HPN. While I was mulling over these issues purely by chance, I came across work that was being done by Dr. Sanjeev Arora on a project called Project ECHO. Dr. Arora is a liver specialist in New Mexico who was worrying about very similar issues, that there was really very little expertise in liver medicine. At various times, he was just one liver specialist in all of New Mexico, now maybe one of 2 liver specialists in all of New Mexico, and that was not enough to look after the growing number of patients with hepatitis C. And what he did was started a tele-mentoring program with a catchy but really very, very true mantra that he was hoping to improve clinical outcomes by moving knowledge, not people. And what he was trying to do was to connect multidisciplinary teams of specialists at the University Hospital in New Mexico with primary care providers at community clinics across New Mexico, with the idea of helping them look after their patients with hepatitis C instead of the patient having to come down to the university hospital. There are some principles of the ECHO model, the ABCDs, if you like. A for amplification, using technology, much like what we're doing now, using Zoom to leverage scarce resources. B is for best practices. This is sort of the gold standard in medicine. We would like to aspire to best practices. And one of the problems is there are not clearly agreed upon best practices in intestinal failure when we think about ourselves. But at least that's the idea in ECHO. If you share best practices, that can improve outcomes. And the idea from case-based learning to master complexity is a well-recognized principle in medical training. That's how all of us acquired specialist training. And finally, Dr. Arora emphasized that you really have to monitor outcomes. You have to use databases to capture what is it that you're doing, what is the impact you're having, and how can you improve. I want to emphasize here that the ECHO model is not the same as telemedicine that many of you may already be familiar with. In telemedicine, the one-to-one relationship between the patient and the physician does not change. All that is saved is that the patient, perhaps from the comfort of his or her own home, can dial in on some kind of virtual platform, see the physician online, and conduct an online consultation and get the opinion and treatment perhaps that he or she needs is increasingly coming into vogue in the context of COVID, certainly. And many of us are pivoting towards telemedicine. It's not always possible in all situations, but where we can, some follow-up visits, some HPN visits, we're able to do with telemedicine. In contrast, what ECHO does, as shown in the upper part of the panel, is that there's an expert team at a hub, say, for example, at Mount Sinai, and we have learners at different spoke sites. Those learners are clinicians who have individual patients they are either struggling with or have some questions about. And there is an exchange of knowledge and learning between the expert hub team, and you can see this as a hub and spoke model. But keep in mind, this is not really, somehow this is not a hierarchy of learning what we and others doing ECHO projects are learning constantly. It's really an all teach, all learn model. There are different things that people out in the community who are looking after patients under sometimes difficult conditions can teach the clinicians who have the benefit of looking after patients in larger academic programs. And ultimately, the hope from ECHO is that patients will actually benefit from this exchange of knowledge. So this was our first ECHO for intestinal failure. Those two pictures literally are the very first ECHO project we did. And the line drawing above it is how an ECHO works. We do it over 1 hour. It's literally like a 1 hour virtual grand rounds. These grand rounds are academic meetings that happen in teaching hospitals all over the world. And the way we run our ECHO is somewhat similar. There's a 5-minute introduction, some housekeeping, and somebody signing in on Zoom presents a case. Keep in mind, no patient details, no specific patient identifiers are shared. This is what's called HIPAA compliant. There's complete patient confidentiality. We don't know the patient's name. We don't know where he or she is living. All we know is that this clinician has a patient that he or she wants to present and discuss and get feedback, and sometimes we'll provide summary recommendations. And at the end of the case presentation, we have an expert speaker from somewhere give a presentation, much like I'm doing today, a 20-minute presentation on a topic of interest to intestinal failure. So we launched this in May of 2019. The physical host is at Mount Sinai, but I want to emphasize that's really all that is based in Mount Sinai. We have an expert medical advisory board. We have people signing in who are experts from all over the US. We're maintaining fidelity to the original ECHO model. We're supported by the ECHO Institute in Albuquerque. Right now, we're doing 2 adult clinics per month. We added a pediatric clinic that's run by my colleague, Dr. Joanne Lai. I say recently, but that's now already about 2 years. I want to leave that website there for a minute. All of our didactic videos are archived for later viewing, and those didactic videos are open to anybody to see. While the Lift ECHO clinics right now are open only to clinicians who have to register, you can feel free to go to our website. It's a little difficult to find. We are revamping our website to make it easier, but you can go there and you can hear. Right now, there are about 100 20-minute presentations, really bite-sized presentations on a variety of topics on HPN, intestinal failure, GLP-2, transplant, surgery, what have you. Very quickly, how have we done? Certainly in terms of attendance, it's steadily increased when we do it in modules of 8 sessions each. The first module, we had 44 participants by the time we finished our 6th module, and we're probably now up to the 8th or 9th module. Our 6th module had an average attendance of 159 sites per session, and you can see the number of participants on the right is pretty significant. We have a pretty steadily growing geographical reach across the US. We're now getting participants from 42 states and District of Columbia. We have a lot of international participants from 6 of the 7 continents, technically all 7. We're trying to figure out who's looking after intestinal failure in Antarctica. And there's a mix of disciplines, which is how it should be. Intestinal failure is patients are best looked after by multidisciplinary teams, and our attendance reflects that. I'll tell you, I said that all our didactics are archived on our website. We don't know who is looking at them, but we know how many people are looking at them and how well they're looking at them. Yes, Big Brother is watching you, so please make us happy. Go to our website, look at the didactics, and educate yourself. We have reported our initial experience with the Left Echo project. This is important. Grant-giving bodies want to see this. And we have several upcoming projects where I am presenting in Vienna next month. We've done a knowledge survey on intestinal failure among European and British gastroenterologists. Yes, Britain is no longer part of the EU. We've just completed a survey of ASPEN members to look at knowledge among nutritionists. So those will be published in the near future. We're just launching a pilot project with the American College of Gastroenterology. This will go live in September. And our idea here is this may be our first opportunity to measure knowledge of ACG members at baseline, have them go through Left Echo, then do a knowledge test at the end of Left Echo. And we want to see, can we improve knowledge? Can we make this knowledge enduring? And we're also hoping we'll stimulate some interest in our field that may hopefully have some workforce implications downstream. There are some important upcoming projects, and this presentation today is our first attempt at trying to keep you up to date with what's happening with Left Echo, because we really want to increase patient engagement. There's a major project that we are getting ready to launch in partnership with Optum Home Infusion, and I want to give a shout out to my friends and colleagues, Penny Allen, Maria, Karim Bakas, that many of you know, Kara Gallagher. They've been really great and very responsive partners in our research effort. Unfortunately, we didn't get funded in the last round, but we've been told we came very close. We've been invited to resubmit with some revisions, and that's happening in the very near future. So we hope to get some major grant funding to allow us to continue this work. But we really want to see, can we improve patient outcomes by improving physician learning in intestinal failure? We are, as part of this project, there's a very exciting effort to develop a new intestinal failure disease activity index. How do we measure? Are patients doing well? Are they doing badly? Dr. Winkler, Marion Winkler, many of you know, has done some remarkable work over the years on patient-reported quality of life, and we want to incorporate that in our research. And we want to offer Left Echo to interested clinicians. Initially, we're going to start this through Optum to demonstrate improvements in knowledge. So how can, where does Oley come in, and how can you engage? Oley has been a remarkable early partner in our Left Echo efforts. Joan Bishop and Lisa Metzger and Beth Gore came with us to New Mexico when we were first exploring doing this. Oley has continued to give us ongoing support with initially a small but important and significant seed grant, and really continued engagement. So again, I will say to you, those didactic videos are there for Oley members, clinicians, patients, family members to see. We would like very much, we're exploring how to do this, to roll out Lift Echo to Oley member clinicians at this stage. If you're a consumer or a patient, you cannot directly participate right now, but you can certainly advocate and push your clinician if you think he or she might benefit or may even be interested to participate in Lift Echo. And the big question we're now asking ourselves, it's not been done in any other echo project, can we launch a patient-facing echo in intestinal failure? I just overshot my time, so my apologies to the organizers. But I want to conclude by saying there appears to be a critical shortage of expertise in intestinal failure and HPN in the US. Telelearning platforms like Lift Echo may help attenuate these knowledge disparities, direct benefit to intestinal failure patients from improving knowledge levels in non-specialist clinicians remains to be proven. Thank you so much for the privilege of the floor.